Yes, a very good evening to all my dear learners. So, we are here with our physiology session where we will be discussing the detailed analysis of the marathon questions in physiology. Right? So, without wasting any time, let's get started. Before that, let me tell you something very exciting that we at Unacademy are starting with a NEET PG revision batch, right? So this batch is going to include revision subject wise and topic wise, and we'll be taking test and discussion. We'll be taking the PYQs, that is the previous year questions, and image based questions. So as far as physiology is concerned, let me tell you that I'm going to take it system wise, right? So it will not be only, like image based, or it will not be of one type, but I'm going to take, as far as concerning physiology, I'll be covering the image based questions, then the conceptual question, then I'll be taking the calculation based questions, and also the graph related questions. So I'm going to go all this system wise so that the things really become easy and interesting to us. Good evening, Muthu. Very good evening, beta. So, are we ready? Yes. So, let's get started with the first question for the day. Right. Yes. So, you can look into the various subscriptions. Now, you are an internal medicine resident, right? And in a tertiary care hospital, and your intern asks you about the importance of cell membrane in the absorption of drugs that he is administering to his patients. All of the following are true regarding cell membrane except. Now remember, this is a very typical clinical based or an ICT based question where you are given a clinical picture or you are given a scenario. But what will be always asked in the nutshell, the last line will be your simple physiology. And always remember that general physiology is really important. So just don't neglect because it is very simple, right? So the options, each layer of the lipid is one molecule thick. The lipid bilayer in the middle is impermeable to CO2. It is an elastic structure. 25% is composed of phospholipids. Yes, very good, Ranjit and Deenal. Very good. The correct answer is B, right? So the lipid in the middle layer is impermeable to carbon dioxide. The lipid in the middle layer is basically possible to, is basically penetrated by the fat soluble substances. Now this can come in the form of an image based question to you, right? So you must know that when we are speaking of the cell membrane, it is having phospholipid layer and these other proteins, and this is called as your fluid mosaic model. Okay, fluid mosaic model, which is also called as the Singer's model. And here the fluids are the lipids and the mosaics are formed by the proteins. Now, the alignment is such like of a pin, head pin. This portion, the head, is actually hydrophilic, that is a water loving portion. And here, these fatty acid chains, they are aligned in such a way that they are facing each other, and this becomes your hydrophobic portion. So there is a small gap you can see between the two heads, that is the intermolecular space, which is going to allow the fat soluble substances, that is your gases, your steroids, to easily pass through. Whereas proteins, water, ions, they need some channels, pumps, pores to get in. As far as the proteins are concerned, these proteins can be the transmembrane proteins you can see through and through the cell membrane, or the peripheral proteins which can be present either towards the cytosol or they can be present either on the outer surface that is facing the ECF, but not passing through and through. So, common examples of your integral proteins are your G proteins, any pump, channel, these all become your integral proteins. Now, as we have seen that the lipids, they are having the fluid property, right? This fluidity is maintained with something which is called as the transition temperature. This transition temperature is maintained by cholesterol. So just imagine you are keeping the butter in the fridge, right? And you are keep getting that butter out and how it melts. So you want a particular temperature because that temperature helps in the lateral diffusion of the proteins, and that is very important for the efficiency of the cell membrane for its transport and enzymatic process. So if it becomes very, thick like a gel or very, very thick like solid, then this movement is not possible. So you want a bit motility or the fluidity of your membrane. Another thing to be remembered that there are no triglycerides, okay, there are no triglycerides in the cell membrane. And this carbohydrate moiety, which is the glycocalyx, is something very important. It is negatively charged, which is going to repel other substances which are negatively charged, like the blood cells, to come and get attached to the membrane. Right? So remember, cell membrane, the transport across cell membrane, then the composition of ions in the ICF and the ECF, and the body fluids. These are a couple of topics which are very, very important in general physiology and not to be missed out. Now, an investigator is developing a drug that is selectively inhibiting retrograde axonal transport, especially of the rabies virus. So, this drug is targeting which of the following? Tubulin, kinesin, dynein, or acetylcholine? So, this is the question which is related to axonal transport. And we know that the axonal transport is antigrade and retrograde. And when we are using retrograde, that is from the axon, okay, from the axon towards the cell, it is using a protein that is dynein. Whereas when we move from the cell body towards the terminal, we are using kinesin. Right? So this is again important question. This retrograde transport is especially important for neurotropic viruses like rabies. Right? It is also carry your tetanus toxin. So these are the important things. It can also carry neurotrophins. What are neurotrophins? These are the nerve growth factors which are synthesized by the target tissue or by the tissue which the cell is, which this neuron is innervating. It could be muscles which will secrete neurotrophins and it will be taken up. Right? Apart from this, remember, dynein, kinesin, then your myosin, and your dynamin. These are also called as molecular motors. Molecular motors, or they are also called as cargo proteins. What is the reason? That they are carrying something on their head and they are moving along with it or taking this along with them. Therefore, they are also called as the molecular motors or the cargo proteins. Right? So, after the rabies exposure, the rabies virus, it binds to acetylcholine receptors and enters the sensory and the motor nerves of the peripheral nervous system, spreading in a retrograde manner to the CNS. To inhibit the migration of the virus and the subsequent brain infection, the new drug is such that it should target your proteins. Okay, it should target your dynein motors. If you consider tubulin, tubulin is a globular protein that is not only going to inhibit the retrograde transport but also, more importantly, the antegrade transport. Remember that kinesin is an ATP dependent motor protein, right? And nicotinic acetylcholine receptors have been implicated as the binding site of the rabies virus to axons, right? So this is all with this question. Let's move next. A 65-year-old a man, is brought unconscious with systolic blood pressure 98 and unmeasurable diastolic blood pressure. He is mechanically ventilated, supplemented with oxygen, and the arterial blood gas analysis is done, which shows carbon dioxide 43 mmHg, oxygen saturation 94%, oxygen content 169 ml per liter, the pulmonary artery pressure of 15 mmHg, and the pulmonary capillary wedge pressure of 7 mmHg is recorded. The rate of oxygen tissue consumption is 325 ml per minute. Which of the following additional values will be sufficient to calculate cardiac output? Now you can see that in this question, lots of values are given, right? These are simply confounding factors which are going to just complicate and confuse you. Actually, what you need is what data is needed to calculate cardiac output, and you can see that this is something which is related to your Fick's principle, right? So if you know the Fick's principle, definitely you can find out the cardiac output. So the options are total peripheral resistance, partial pressure of inspired oxygen, left ventricular end diastolic volume, or the pulmonary artery oxygen content. Boys and girls, the answer is very simple. The pulmonary artery oxygen content. What we are calculating is the cardiac output by Fick's principle. What is Fick's principle? Cardiac output is equal to oxygen consumption, which is per minute, divided by the atriovenous oxygen difference. Okay, atriovenous oxygen difference. So the pulmonary artery oxygen content, that is the oxygen content of the venous blood, is missing in this value, which we need to find out, right? So you can see oxygen content of the arterial blood is given 169 ml per liters. What is needed? Oxygen consumption is needed. We only needed the venous oxygen content, which we can obtain. So a very simple question, but sometimes it becomes confusing. But remember, it is simply the Fick's principle for cardiac output estimation. So again, you can just add on over here. For functional residual capacity, you use the helium dilution method, then nitrogen washout method, and body plethysmography. Body plethysmography. Similarly, if you are asked to calculate the anatomical dead space, the anatomical dead space is calculated by single breath nitrogen technique, which is also called as the Fowler's method, right? Then if you have to calculate say the physiological dead space, that is by the Bohr's equation, right? So cardiac output can also be calculated as heart rate into stroke volume as a calculation based question. We know that blood pressure is equal to cardiac output into total peripheral resistance. So cardiac output is blood pressure upon total peripheral resistance. Another way of calculating it. So these are very, very important calculation based questions. Please remember that these are compulsorily a part of your examination. They are a part to study. So whenever you study physiology, you need to be clear with the questions which can be in the form of concepts, which can be in the form of alignment, like alignment with micro, alignment with your medicine, with your surgery. Especially thyroid can be with surgery, CVS, RS, CNS with medicine, and micro is usually integrated with GIT when we study the microorganisms affecting the intestinal reabsorptions, especially diarrhea, are correlated. You need to study graph related questions and calculations apart from the single one liners. So whenever you are covering physiology, just take into this point into your mind that I must cover this pattern in physiology. As I told you, when the total peripheral resistance is used, then that time cardiac output can be the mean arterial blood pressure upon TPR. But here both of these were not given, right? And suppose if you have to calculate using end diastolic volume, cardiac output is equal to heart rate into stroke volume. But to calculate the stroke volume, you require end diastolic volume minus end systolic volume. So this data was also not given to us. So these are the three ways by which we can calculate our cardiac output. Moving on next. A group of doctors is studying hemodynamic regulatory mechanisms in a human volunteer. The volunteer is administered a stimulant drug and a sudden increase in the blood pressure is being observed. So as the drug is administered, there is a rise in the blood pressure. It is hypothesized that increase in the blood pressure causes stretching of the atria. Increase in the atrial stretch will likely result in what of the following change? Increased excretion of potassium and hydrogen, vasodilatation and decreased platelet aggregation, decreased reabsorption of sodium, or increased reabsorption of solute-free water. Yes. So this question is related to decreased reabsorption of sodium, right? This reflex is also included as a volume reflex. Like, so whenever there is increase in the venous return to the heart, right, there is going to be the stretching of atria, especially your SA node. This causes increase in heart rate. So increase in the venous return to the heart causes increase in the heart rate. This is your Bainbridge reflex. Right? But increase in the volume is also going to bring about the stretching of the atrial receptors, which bring about increase in the secretion of ANP, that is atrial natriuretic peptide, which is coming from the left atrium. This atrial natriuretic peptide causes increase in the GFR because it causes dilatation of the afferent arteriole. It basically causes the relaxation of the glomerular mesangial cells. So when there is relaxation of the glomerular mesangial cells, there is increase in GFR. That increase in GFR is going to result in loss of water, that is diuresis, and apart from this, loss of sodium, that is natriuresis. Right? So the Bainbridge reflex is increase in heart rate and increase in the loss of sodium is brought about by increase in ANP. So whenever the volume load is increased, okay, there is going to be the increased secretion of ANP and the body will decrease the secretion of ADH. Remember that when we speak of the baroreceptors, these baroreceptors are of two types. One, high pressure baroreceptors, which are your carotid and aortic sinus, that is supplied by the 9th and the 10th nerve, that mainly respond to your high blood pressure. There are certain low pressure baroreceptors which are present in the atria, in the ventricles, in the pulmonary circulation, which are not responding to blood pressure. They respond to the central venous pressure because they respond to venous return. Right? They respond to venous return. So increase in the blood volume is going to cause stimulation of the low pressure baroreceptors. These low pressure baroreceptors basically decrease ADH so that the water reabsorption is not taking place. This is very important as far as the cardiovascular reflexes are concerned. The Bainbridge reflex, volume reflex, Cushing reflex, CNS ischemic response, chemoreceptor reflex, baroreceptor reflex. So whenever you are studying, please ensure that all these reflexes are included. The other one, which we called as the Bizold-Jarisch reflex, is caused by a chemical substance, that is serotonin. So cardiovascular reflexes are very, very important. Apart from this, there's usually an MCQ on the nucleus tractus solitarius, because it is the nucleus tractus solitarius that receives the afferents from the periphery. Next. There is a 40-year-old male which is having backache, hematuria, nausea, and an intravenous speleogram was done which confirmed renal calculi. And there is presence of opaque stones which are suggestive that there is presence of calcium oxalate stones. Right? Calcium oxalate stones. And there is an increased incidence of hypophosphatemia. The question says that the renal clearance of phosphate is increased by which hormone? Aldosterone, parathormone, norepinephrine, or vasopressin. So the question is very simple. It is suggesting you increase in calcium and decrease in phosphate. This increase in calcium is reflected by the presence of calcium stones, which is this hormone. This is definitely, no confusion, your parathyroid hormone. If it is increase in phosphate and increase in calcium, it is vitamin D. If it is decrease in phosphate as well as decrease in calcium, it is calcitonin. Increase in calcium, decrease in phosphate is PTH. And these are the three important hormones which are taking part in calcium regulation. Aldosterone, norepinephrine, vasopressin, they are not related directly to calcium. So there should not be any confusion. Now the specific action of your PTH on kidneys is to increase the distal tubular reabsorption of calcium. Okay, to increase the distal tubular reabsorption of calcium and to decrease the proximal, especially in the PCT, the reabsorption of phosphate and bring about phosphate urea. So because PTH is a protein hormone, it will be having receptors on the membrane. These receptors are G-linked receptors, that is linked to the G protein. GS means stimulatory, using the second messenger cyclic AMP, increasing the protein kinases and causing phosphorylation and inhibition of the sodium phosphate cotransporter. This sodium phosphate cotransporter is inhibited by your PTH. Because of this, there is failure of reabsorption of phosphate and phosphate is lost in urine, that is phosphate urea. Right? So, as soon as there is a decrease in calcium, the first hormone to be released will be PTH, not vitamin D. This PTH will act on the kidney, it will act on the intestine and in the bones. In the bones, it increases the bone resorption. In the intestine, it causes increase in the calcium absorption. This action of PTH is called indirect action. Why indirect action? Because PTH will increase the formation of active form of vitamin D. Active form of vitamin D. It will increase the formation of active form of vitamin D, which takes place in the PCT of the kidney. This vitamin D will then increase the calcium absorption by increasing cal binding in the intestine. Therefore, remember that the action of PTH is directly on the bones and kidneys, but it is indirect in the intestine. Okay, it is indirect in the intestine because it is brought about by vitamin D. Now, a male newborn at full term is evaluated for low urine output 24 hours after birth. The pregnancy was uncomplicated. The renal ultrasound revealed dilatation of the left renal pelvis and calyces. Which of the following embryological tissues had an error and the developmental error is seen? Options are pronephros, ureteric bud, metanephric blastema or urogenital sinus. Yes. So the correct answer becomes ureteric bud. Okay, this is more much of related to embryology. The caudal end of the mesonephric duct branches off and forms the ureteric bud. This is going to give rise to your collecting ducts, calyces, renal pelvis and ureters. The canalization is completed by 10th week of gestation, with the uretropelvic junction being the last to get canalized. An impaired canalization is very commonly resulting in the uretropelvic junction, and this results in the uretropelvic junction obstruction with reverse urine flow into the kidneys with increased pressure, and that can result in hydronephrosis. The pronephros is the first precursor of the developing kidney. The metanephric blastema differentiates into glomeruli, proximal tubules, loop of Henle, distal tubules. The urogenital sinus differentiates into bladder and urethra in both the sexes, as well as prostrate in the male and vagina uvula in the female. And you must remember that the uretropelvic junction does not originate from the urogenital sinus, right? So the question is a bit related to your embryology. So moving on with the next question. A 32 years old male has got a complaints of abdominal pain, diarrhea, flushing, fatigue, generalized pruritus. Examination shows pallor, dry mucous membrane, and bone marrow shows a dense infiltration of atypical leukocytes with basophilic granules. Genetic analysis shows a mutation in the KIT gene. The patient is at greatest risk for which complication? Stress-induced cardiomyopathy, laryngeal edema, gastral ulceration, or mucosal neuromas? Yes, definitely the answer is C, that is gastric ulceration. Now, leukocytes with basophilic granules, they describe your mast cells. Dense aggregates of the mast cell on biopsy and a finding that there is KIT mutation are diagnostic of mastocytosis. This manifests as diarrhea, flushing and pruritus. So mastocytosis means proliferation of the mast cells, and you know that the mast cells are rich in histamine, right? The basic nature of histamine or the effect of histamine causes pruritus, flushing, but we know that histamine also triggers gastric acid secretion, which can potentially result in gastric ulceration. So this patient is going to be treated with antihistaminics, mast cell stabilizers and steroids. So the cause of ulceration over here is histamine, and in the history we get an idea of histamine. Yes, it is an allergic-like condition. Checking out to the other, other options, the stress-induced cardiomyopathy is a long-term complication of pheochromocytoma, which is presented with a classical triad of headache, sweating, palpitation, and hypertension. Laryngeal edema is common with anaphylaxis, type 1 hypersensitivity. Mucosal neuromas are more common with the men to be with an increased risk of medullary, thyroid cancer, pheochromocytoma, and marfanoid habitus. Right? So this is all with the question. Let's move forward. A 22-year-old patient's X-ray who's got renal tubular acidosis shows opacification of the right lung field, fractures of multiple ribs. Lab investigation shows hemoglobin 14.8, leukocyte 10,300 per cubic mm, and platelets are 1.7 lakhs or 1.75. Glucose 77. Infusion with 0.9% saline was begun, and lab shows hemoglobin 12.4, platelet count 104, prothrombin time 26 seconds, and the partial thromboplastin time as 63 seconds. How are you going to manage this patient? You will give transfused packed RBC, fresh frozen plasma, and platelet in the ratio of 1:1:1, or transfuse whole blood and administer vitamin K, transfuse fresh frozen plasma and platelet, transfuse fresh frozen plasma and vitamin K. So the correct answer is definitely A. Very good, Muthu. The answer is A. The patient fulfills the criteria of your TIC, right? And in TIC, the best treatment is going to be fresh frozen plasma, pegged RBCs, and a platelet concentrate with the ratio of 1:1:1. Right? So the goal of this transfusion will be to correct the coagulopathy, prevent uncontrollable blood loss so that you can have a prescribed hemoglobin level. If you look into the other options, whole blood, it will have RBC, plasma, platelets. The transfusion of the whole blood is not much indicated because though it is relatively deficient in clotting factors, it will have also high amount of potassium, ammonia, and hydrogen, which will create further problems in dealing with resuscitation. Fresh frozen plasma and platelets aims to correct the new coagulopathy, but the patient also needs treatment for TIC. Fresh frozen plasma is a part of treatment of TIC, but other components have to be considered. So vitamin K is administered to treat some coagulopathies in stable patients, but vitamin K takes long hours to take its effect, and here the patient is unstable and you require immediate correction of coagulopathy. Therefore, the option A becomes the best answer for this question. Right? So I hope it was crystal clear. So let's move on to our next question. So this is the image which is related to the question. Right? Let us see the question now. A 66-year-old man is brought to the emergency department because of shortness of breath and confusion. Pulse is 98 per minute. Blood pressure is 109/73. He is oriented to person but not to time and place. That means he can identify the person but he is not oriented to the time and place. A graph of the breathing pattern is shown and the oxygen saturation is shown. Which of the following additional findings is most likely present in this patient? A ventricular gallop, a rib fracture, barrel chest, or a fruity bread odor? Yes, it is a ventricular gallop. With a ventricular gallop, the patients with advanced heart failure develop Cheyne-Stokes breathing, which is a characteristic breathing which is shown over here. Hyperapnea with apnea and again followed by hyperapnea. Advanced heart failure, apart from this, neurological disorders, stroke, traumatic brain injury, this can also result in this pattern of breathing, that is the Cheyne-Stokes breathing. So this is very important image-based question, apart from a clinical history image-based question. If you look into the other options, a rib fracture. If it is a rib fracture, there will be lots of pain. Especially the pain will increase when the person is taking a deep breath. Right? So this kind of a patient will have a rapid shallow breathing, low tidal volume. And you will not get a very typical breathing pattern in this. If you take a barrel-shaped chest, barrel-shaped chest is characteristic of COPD, right? Which is going to manifest with severe dyspnea. If you see a fruity bread odor, it is characteristic of accumulation of ketone bodies, diabetic ketoacidosis, and the patient will not have a Cheyne-Stokes breathing. He will have Kussmaul's breathing, which is deep, regular breath. There can be a normal or an altered state. So the types of abnormal breathing, is one of the high yielding question in physiology as far as RS is concerned, right? So this is all for this question. Let's move on to the next one. A 36-year-old woman with a history of schizophrenia comes to clinic because she thinks that she is pregnant. Remember, she is schizophrenic, so she can think anything. Her last menstrual period was 3 months ago. She has gained 4.5 kg weight. On examination, there is a white discharge from nipples. A urine dipstick pregnancy test is negative. Which of the following drug is likely to cause this type of finding? Bromocriptine, bupropion, haloperidol, or fluoxetine? Right? Yes. So the correct answer is definitely A. That is haloperidol. I'm extremely sorry. Yes, it is haloperidol. The option, yes, it is haloperidol. Now, the condition which is being depicted to us is hyperprolactinemia. Hyperprolactinemia can be caused by dopamine antagonist, right? We must remember that dopamine suppresses prolactin release, whereas the dopamine antagonist and the thyroid stimulating hormone can increase it. TSH is also known to increase prolactin apart from increasing your T3, T4. Haloperidol is a typical antipsychotic. It is dopamine antagonist and can cause these symptoms. Other causes of hyperprolactinemia which we must take into consideration is adenoma or a very severe hypothyroidism. Because in hypothyroidism, there is going to be a decrease in the level of T3, T4, which causes a release of TRH and increase of TSH, and these factors also increase prolactin. Now, bromocriptine is a dopamine receptor agonist which is used to treat hyperprolactinemia and Parkinson's disease. So, it is not the cause of hyperprolactinemia, but it is something which is used to treat hyperprolactinemia. So, don't get confused. Bupropion is norepinephrine and dopamine reuptake inhibitor. Fluoxetine is serotonin reuptake inhibitor that can cause weight gain, insomnia and sexual dysfunction. Right? Two important things to be considered over here. The prolactin levels, they are same in both the sexes. That means in both male and females. Only pregnant and lactating females will have more prolactin. So a misconception that the prolactin levels may be more in the female is a wrong answer. Prolactin levels are more only in females when they are pregnant or when there is lactation physiologically, right? One of the very important function of this prolactin is to suppress GnRH. This is going to suppress the LH and the FSH. That means it can inhibit ovulation in females and spermatogenesis in males. So hyperprolactinemia in females is associated with anovulatory cycles. This is physiologically present at the time of lactation, and therefore it is said that during lactation it is a natural contraceptive for the female, though it is not very hard and fast, but the cycles are anovulatory. Right? So one of the very important effect of prolactin is to inhibit GnRH. Both males and females can suffer from infertility with high prolactin levels. Another important thing, we see that hypothalamus, the hypothalamus is regulating, I'll write over here, the anterior pituitary. Okay, hypothalamus is regulating the anterior pituitary and it is secreting all releasing hormones, right? Like the growth hormone releasing hormone, corticotropin releasing hormone and so on. But it is secreting PIH, that is prolactin inhibitory hormone. Prolactin inhibitory hormone, that is chemically dopamine. So if there is no connection between the hypothalamus and the pituitary, that means any condition where the hypothalamus is not regulating your pituitary, there will be decrease in all the hormones, that is decrease in the growth hormone, FSH, LH, decrease in the TSH, all these hormones will decrease. But the only hormone that will increase will be prolactin. The reason is that the prolactin regulation by the hypothalamus is not by a stimulating hormone, it is by inhibitory hormone. So if the hypothalamus is not secreting, or if the prolactin inhibiting hormone is not able to reach from the hypothalamus to the pituitary, the prolactin levels will be high. So this is one of the very important consideration regarding prolactin. Also for growth hormone, you have got growth hormone releasing hormone and growth hormone inhibitory hormone, that is chemically somatostatin. Somatostatin. But out of these two, the important one that is regulating the growth hormone is the growth hormone releasing hormone, right? So this is something very important considering your general endocrine principles. So the basic principles of endocrines, like especially the classification of hormones, receptors, the mechanism of action and the second messengers. This is very important and you must consider these factors very nicely in physiology, right? So with this, boys and girls, before I end up the session, I would like to tell you that please consider your brain just as a magnet. Okay, a magnet. It keeps on attracting whatever you attract. You attract positive thoughts, happiness, health, blessings, success, you get those. So always remember that attract positive things in your life, which you can always develop by an attitude of positive thoughts. So it is not only the studies that help us, that we study and we pass or we get whatever rank we want. Our thoughts have got a very important impact on our life. So be very, very optimistic, very, very expressing gratitude, and you believe and you shall receive. You just have to bring positive thoughts into your mind. You have to work on those thoughts, right? So thinking that PG seat is very difficult, I may not be able to get it. Why don't you think that there are so many people who get the PG seat? I'm going to be one of them. Attract positivity, be optimistic, express gratitude. The more you develop the feeling of expressing gratitude and abundance, more you will be on the side of receiving. Right? So, being positive is the first thing to be done. When people say that this is a glass, some say this is half filled, some say this is half empty, some say, thank God I have got half glass. I say, thank God I have a glass. Right? So I never say whether it is half empty or it is half full. I always say, thank you God for the glass I have. Let it be empty, let it be filled, but at least I have a glass. So be very, very optimistic towards your life and receive lots of blessings by being very, very hardworking, persistent, and positive. So that's all from this side, your mentor at An Academy, Dr. Reena Kaur. Right? So be very, very uh, just persistent, disciplined, plot a graph for yourself, and compete with yourself. So thank